how health centers are, okay, sorry, that
Sorry.
there, forgive me guys. I lost my flow there. And how health centers are assisting individuals that are experiencing homelessness, individuals are experiencing housing instability, and what work they are doing in order to keep folks safe during COVID. There is a fundamental disconnect, how you will, if that we've all been told to quarantine, we've all been told to stay home, and yet people experiencing homelessness would love to be able to stay home. That's unfortunately not an option for them. So there's really been a quick and evolving partnerships between health centers and folks that are doing the housing related work. And so we're going to talk about some best practices that we're seeing out in the field right now. Just to give us a little bit about CSH, CSH is a HRSA training and technical assistance provider. We're up to a touchstone for new ideas and best practices. We do training and education like work here. We do lending. We're a community development financial institution. That means if you're looking to develop a new supportive housing program, we are often the first funding in order to do that. We do policy related reform and then consulting and technical assistance. Our North Star is increasing community supportive housing capacity and increasing supportive housing quality. Next slide. The two of us from CSH. Jamie, do you want to introduce yourself?
Yes, hi, good afternoon. Thanks everyone for taking time to join us today. My name is Jamie Blackburn. I'm a program manager with the New England region based in Amesbury, Massachusetts.
And I'm Marcella McGuire. I'm CSH's National Director of Health Systems Integration, and I'm coming to you from Philadelphia, Pennsylvania. Next slide, let's talk about it. Now we want to hear where you are and where you're joining from. So my understanding is that if you are on your computer, click at the top, go into full screen, click at the top, view options, click on annotate, find stamp. Okay, I'm just practicing for myself. And let's not draw a stamp. And tell us where you're calling in from. Like the hearts. Seem to have a good cross section of the country here. All right, this is great. Good to see everybody on their dots. All right, go to the next slide, please. Or also tell us in the chat. If you can't make the annotation work, tell us in the chat. All right. So for today's agenda, we're going to talk about understanding what are called alternative care sites. Alternative care sites are sites that communities have put up in order to reduce COVID spread, both for vulnerable populations, individuals who are not able to quarantine, et cetera, and then also places and people that are how should I say this, that are housing unstable, or maybe there's a lot of people living in a small space, one person's diagnosed, we don't want that one person to go back into that household and infect everyone else in the household, there's not enough space to separate for very low income households, etc. And so there needs to be another option for them. So we've been seeing these called alternative care sites today, and we're going to hear about innovations and practices and learning from some of the experts of what we're seeing across the US. Jess Gelasio is going to talk about what they're doing in Bangor, Maine with Hope House Health and Living Center. Healthcare for the Homeless, Naomi and Amy from Hennepin County are going to be talking to us. And I believe we may have someone on from Los Angeles as well. We've had some trouble communicating there. So I hope Dana can join us as well. All of these entities that we're talking about are grounded in health center work. They are health centers, and they are being pulled out of their clinics into their communities. They're all healthcare for the homeless products, so this is probably, less a jump for them to be offering services in another site, but it is a change and a transition, and it's really important for folks to think about this in terms of both COVID context, et cetera. So for now, I'd like everybody to meet our panelists. Amy, your picture's first up the slide, so you want to say hello to everyone?
Yes, my name is Amy Gordon. I'm a family nurse practitioner that works with the Hennepin County Healthcare for the Homeless Project in Minneapolis, Minnesota.
Great. And Naomi?
Yes, sure. My video is not working, so I will just speak and hopefully you can hear me.
You sound great.
That's great. Good. So I am also a family nurse practitioner. I work for Hennepin County Healthcare for the Homeless in Minneapolis.
Great. And Josh?
My name is Josh D'Alessio. I'm the director of the Hope House Health and Living Center, which is a community health center and low barrier shelter in Bangor, Maine.
Great. And I don't know whether, oh, back. I don't see Dana on, so I'm going to move on from there. Okay. Next slide. Thank you. So alternative care sites. What's really, really crucial and essential about these sites is that the partnerships are very much leading the way. I want to give a huge shout out to National Healthcare for the Homeless. This has done just such an amazing job supporting from the very beginning days of the pandemic back in March or April, supporting, advocating for these sites to make sure that they happen, supporting these sites, and trying to connect all of you across the country who are doing this work, who are literally making this up as we go. And just also want to highlight for everyone the challenges of, if we all think back to March and April, we take a breath and think what incredible crises they were in, and how much knowledge we didn't have, and watch how this is evolving, and make those changes needed to the program. These were not programs that we had 2 months, 2 years, or 2 days practically. They just came up, and then suddenly we had to figure out how to support them. So know that this is an evolving model, and I think the presenters today will give some really great ideas in regard to how they've evolved their model over time and what they're doing to address the various and diverse and heterogeneous needs of the folks that are staying in these sites. Again, huge shout out. This is from National Healthcare for the Homeless's COVID dashboard. They're doing some really great work on telehealth. They're doing great work on collecting data. They're doing a huge job advocating that your community is really looking to, particularly in this really dark time of the pandemic, making sure that they prioritize and support unsheltered populations and the unique challenges that they bring, talking about medical respite, and then also having a COVID dashboard looking at testing and how we make sure that people who are experiencing homelessness and housing instability are prioritized for testing to keep themselves safe, to keep the community safe. It's my understanding that today or sometime in the next day or so, National Healthcare for the Homeless will also have a new brief on vaccine distributions, best practices, and how to talk to people about vaccines, how to engage, and how to make sure that the folks that you're serving every day, as well as yourselves, are first in line. It feels like a really exciting day to be doing this. I don't know if folks saw, but we're seeing the first folks in across the country getting access to the vaccine. I know my headline that I got was a African-American healthcare worker receiving the vaccine, an African-American healthcare worker delivering the vaccine, and just the real power, because we know of how inequitable the impact of COVID has been. And so really exciting to see people first in line getting the vaccine and the hope and possibilities there. So again, shout out to a lot of great work from Healthcare for the Homeless and much more comprehensive. There are a couple of questions I want to make sure that you're each thinking about the alternative care sites in your communities. First, have they centered equity? And we say that to mean we've seen all of the data that's coming out. We're seeing who's getting infected. We're seeing who's hospitalized. We're seeing who has severe cases. We're seeing who's passing away. And we're seeing that communities of color are just much harder hit in this. So we want to make sure that as your city, your continuum of care, your entity, public health department sets up these alternative care sites, have they centered equity in their response? And we'll talk about some of that response and key questions. What question is access? Who are served? How do you get there? How do you identify? Who gets identified in the community? What data tools? What outreach and engagement tools? What processes? So who gets into these sites? How do they get there? How easy is it to get? Capacity is an also issue. Those of us who work in the homeless field know that as capacity gets tighter, we add barriers, we add, we add challenges, we add, oh, but you have to do this and see this person, and then fewer people get through. So does your community have the capacity it needs to serve? Communities are in a really tough spot right now locally because the CARES Act money must be spent by a certain amount of time, by the end of this month, I believe, et cetera. So so we want to talk about the creative strategies that they're using and hope for the future that there will be future funding to keep these sites. What services are offered in site? One of the big first questions we saw was questions about when the sites first came up, it was just enough to basically have a hotel and make sure food got to people, and then we were all done. And we found that, not surprising to anyone who's worked in a healthcare for the homeless program, that people are presenting with really complex needs. And so there's been a variety of services that are added to the sites, and we're going to hear from our presenters today about how they're doing that and in different kinds of sites. A quick question you want to ask is, how long do people stay? We're seeing some communities that are keeping people the 2 weeks of a quarantine site, i.e. this is when they're infectious and we're making sure they stay inside and they're infectious, but then they're returned to homelessness. We're seeing other sites, people with multiple challenges and needs, trying to hold on to those people and allow them to stay in sites until they can move to housing. And just in some controversies we're having right now in Philadelphia, I will shout out that housing is supportive housing, affordable housing, housing where people have a lease and the services they need to be successful long-term. That's what counts as housing. So how long, ask for your alternative care sites, how long do people stay? And when they're discharged, where are they discharged to? HUD's released new guidance on creating cohorts for a rehousing strategy, and we've got other upcoming work next year that we'll be talking more specifically about rehousing, but shout out to all of the HUD guidance on these issues. It's going to be really important that a site is taking a harm reduction approach, particularly to substance use. We imagine that people experiencing homelessness are going to have a higher rate than expected of substance use challenges, et cetera. The trauma of homelessness leads to a lot of that. So I wanted to highlight Healthcare for the Homeless's guidance on operating with a harm reduction approach. And I'm really excited for Josh and Amy and Naomi's work that they're going to tell us specifically how to do that. And then talk about discharged. Why might someone be discharged against their wishes? And where are those people discharged to? There is nowhere to discharge someone to in a public health pandemic where the potential for them to become ill isn't greater if they're discharged. There is no place for them to be discharged to where there's potential for themselves to come ill, and if they're still in the infectious part of the disease, also to spread that. So some key questions you should be pushing in your communities and asking about into those sites. Next slide, please. All right, so today we're going to talk to our presenters are going to talk about the models of care, what they're doing actually in sites, the models of collaboration. Very few providers have the housing expertise, the human services expertise, the healthcare expertise in order to bring all of those together. So if you only have a couple of those pieces, you want other partners. So let's talk about models of collaboration. We can talk about some common challenges and some really uncommon solutions. And so I believe with that, I am turning it over to, next slide, please. I believe it's Josh. All right, Josh, take it away. Speaking of uncommon solutions, you've got many.
I've got many. Thank you. I really thought I was going second, so I just took a quick breath, but I'm prepared and ready to go here. The presentation here should be about 15 minutes, maybe not even that long. And I understand that we have a half hour when we're done for questions. And I'll just point out up front that this presentation sometimes works at cross purposes with two of our components, and that's operations and services. And there's a little bit more to the nuance of this presentation than actual policy. So if there is anything that needs clarification, please ask when we have the question and answer period. But Penobscot Community Healthcare operates a facility called the Hope House. And the Hope House has a campus with a community health center. We're part of an FQHC. And I believe we're either the first or second largest FQHC in New England. On this campus, we have a low barrier, what was a 66-bed low barrier shelter, targeting people struggling with substance use disorder. We also have a 48-unit transitional housing program for people who are formerly homeless. After COVID hit, and within a couple of weeks, we stood up a hotel, like happened all around the country. Ours is a 110-room quarantine and isolation hotel on the top floor, and a space for social distancing on the bottom floor. So in the after COVID, we've spread out now, and we provide services on a nightly basis for about 170 people. At the core of our services is a medical home model of care and a 7-member peer-based outreach team for people struggling with substance use disorder. Those two components helped us glue a lot of this together. Next slide, please. What I'm guessing most of this group knows is that at the onset of the first wave of COVID, and prior to people needing quarantine and isolation, persons who were houseless saw a huge disruption in their economy. This is germane to how we approached our quarantine and isolation facility. One, at least in Maine, where returnables, where cans and bottles being returned for 5 cents or 10 cents a piece is a common part, or maybe even a backbone of the economy. If you're experiencing homelessness, that immediately went away. Survival sex opportunities went away. Another component of the economy, rolling cigarettes for a quarter or 50 cents a piece, went away, and so did day labor. So almost immediately, people struggling to maintain with their substance use and other needs suddenly lost all of that. And that's on top of having nowhere to go. Next slide, please. So when we experienced people experiencing homelessness in the community becoming positive or persons of interest for COVID-19 and needing a place to quarantine and isolate, we wound up immediately noticing that number one, everyone's human, and when you're told that you have to quarantine and isolate and you're not prepared for it and you don't have any money or access to it, coffee and cigarettes became an immediate concern. And obtaining that was difficult. But just a couple hours after that, anybody struggling with substance use disorder who was not sitting at a state of readiness for change, in other words, then pre-contemplation and not thinking about changing, maybe it hadn't crossed their mind, or maybe it had but not ready yet. Being told you have to quarantine and isolate in a room all by yourself and away from your social network, it wasn't time to change and go into a recovery program at that point. So we saw a lot of need that first night and second night and third night for people struggling with alcohol use disorder to acquire some alcohol so they wouldn't go into the DTs. Obviously one line of opportunity would have been a medically managed withdrawal in a hospital. But if you're not ready for that, then you're not ready for that. So taking a client-centered approach, helping people find alcohol became a concern, at least a top-level issue. Other drugs like opioids and whatnot, though clearly less deadly in the withdrawal process, painful for many people. And as people became dope sick, maybe air quotes for that, it became necessary to figure out how to manage that as well. Next slide, please. This is where we ran into a significant crossroads. Operationally, we have bounds and regulations to maintain that have some behavioral expectations and rules, like you can't bring a weapon on property, like you shouldn't have drugs or alcohol on property, and things like that. Those operational issues became a challenge for people struggling with substance use maintenance. So we took a bifurcated approach. And like we do in some of our other programs, and this is where the nuances kick in, we separated our operations from our services with a strict delineation. And we, I guess, deputized our peer recovery coaches and peer recovery outreach teams to be the service entity in this hotel, and separated them from all the decisions around operations, which means, you know, the group of people tasked with managing the rules of the hotel were separate from people providing services to make sure people could have access to what their needs are. So our peer recovery coaches and peer recovery specialists and peer recovery navigators went into the hotel very early on. They go in day one now, or day, you know, hour zero now, but at the beginning it took us a couple hours to figure it out. And they build relationships with people who have to quarantine and isolate. That's their primary function. Earn trust, build relationships, and then help people navigate their needs of quarantine and isolation. And it turns out that they also provide a significant amount of socialization opportunities. They connect everybody with a cell phone or a tablet or both, and are in constant contact with pass down for people who are in high needs. Next slide. So originally there was a big demand for tobacco and caffeine. I know if I had to quarantine and I didn't have coffee, I'd be in harm's way real fast. So some of the early discretionary funds we had were for caffeine. It was a little bit more difficult for us to buy tobacco, though that was a reasonably big need. In managing the needs of somebody quarantined and the needs of the community to keep people, you know, safe from others spreading the disease and keep people safe so that they could recover, it became obvious that as a health center, we had to provide access to tobacco products. Now, we planned and did all this way up front with patches and other harm reduction nicotine items, vape patents and whatnot. But if you're quarantining and in withdrawal from other drugs, I guess nothing replaces a cigarette. So we had to find a way to get the tobacco products, and we did it. We used some discretionary funds, and through our housing programs, we bought some tobacco. That led to some ethical challenges right up front and funding sources, because oddly enough, there isn't any funding to go out and buy tobacco outside these discretionary benevolent funds. So we created two things. One is the drop zone. The drop zone is an amnesty area where people who are quarantining and isolating can have friends or family or other professionals drop off a backpack or a bag of things that they might need in this drop zone. They can then retrieve it, and we've got this complicated walkie-talkie process of clearing halls for people who are positive or persons of interest, where they can go out to this drop zone while we watch the bag on camera, and they can go get it and bring it back to their room. This solved the problem. This solved a big problem of us having to go out and purchase tobacco products and whatnot. We quickly found, though, that this drop zone only really worked for people who had established relationships with people on the outside and had somewhat of a social network and access to any cash. That was the only way to really get needs met. If you didn't have that, then you didn't have the same opportunities to have things dropped off for you to help your quarantine and isolation. So recognizing that there weren't any funds, we came up with a per diem rate for staying in quarantine and isolation. The rate we came up with was $7.50. Our state housing authority agreed with the need to provide a per diem to people quarantining and isolating who had no access to their regular economy and no access to cash to get their needs met, as somewhat of an encouragement to stay quarantining and isolating. So our Maine Housing, our state housing authority, provided us with that $7.50 a day, which we arrived at as being the average price of a pack of cigarettes, and not too much if someone were to have one of their friends buy some alcohol or a small bag of drugs. It would not be an amount that was concerning to somebody if they were to use in their room, that would put somebody in too much harm's way. So after putting those two programs together, and am I okay for time? About 2-3 minutes. Thanks. After putting those two programs together, or those two components together, we established a protocol where our peer navigators do their very best to meet with people struggling with substance use disorder and build trust as soon as possible, and encourage that people never use alone, which is tough when we're trying to tell everybody to quarantine and isolate, right? So if we can have 3 or 4 people struggling with a similar substance use, you know, they're allowed to go in and out of each other's rooms, and we encourage that activity take place. 2, if somebody does receive a drug or an alcohol, even though they're not supposed to, our peer recovery coaches will build enough trust that they won't report that to the operations side of things, and encourage people, if they do receive a package, to contact them within 7 to 10 minutes of when they come back inside after retrieving it, or if they are using, to contact after or before use. And amazingly, it works. I get goosebumps every time I get to this part of talking about it, because people pick up the phone and they call the peer navigator and they say, hey, just wanted to let you know, it's cool or it's not cool, or, you know, can you come check on me in 10 minutes or 5? I should add that we do provide everybody with extra amounts of Narcan. There's Narcan all over that floor, naloxone. And there's strong efforts made to help people choose a standing order that we have for Suboxone and connect people to methadone and other treatment opportunities. But in the end, if the decision is made that somebody might use, we want to preserve that trust so that we can prevent as many unnecessary deaths as possible. And knock on wood, we haven't had any. And whether that's, well, I mean, there's no arguing that that's good. Next slide, please. So that's where all the nuances kind of crash into each other. But some of the key components of the program that we put together is making sure that everybody has a phone with minutes. And if somebody loses their phone or sells their phone, we don't publicize it, we just get them another phone. We consider having access to communication more important, or as important as the roof over the head, a place to quarantine, and food. You know, after people eat, we provide them with another meal. And the population that we're serving here often go through phones. You know, it's something that can be sold, that has value to acquire other things, and sometimes broken. So we just provide phones, and maybe 3 phones is the most number of phones we've given to one person in this. So, but we don't make a big deal out of it. The per diem rate at $7.50 seems to be adequate. I'm sure it could always be more from anybody's perspective, but it seemed to work for us. A standing order of Suboxone is pretty cool. Of the 52 or 3 people who came through the program in August, 3 people chose to go on Suboxone and previously weren't. I consider that like a huge success rate, because I can't go out and do any outreach to 50 people and have 3 people say yes. I mean, that's, so I think that's a success. Peer recovery coaches with strong supervision and training is another critical component. We're walking a lot of ethical bounds with this, and 1 hour a week individual and 1 hour a week of group supervision, I think, was absolutely necessary to make sure that we were staying on track. Agency support was hugely important. I'm not sure a lot of organizations have an appetite for how close we are on some of these bounds, but I'm grateful that PCHC is of that mindset. And the last component is that it can't be business as usual, period. We're in the middle of a pandemic and in the middle of an opioid epidemic, and those two crash really hard when you need to quarantine and isolate. And there's more than just the consideration of the person before you. We're dealing with a public health matter at the same time. And I think if we're going to be successful, we have to think outside of the box and walk right up to those bounds. That's all I have. So thank you for listening today. And thank you for the opportunity to present.
Well, thank you so much, Josh. I'd like to just comment from the chat. We had a comment from Maurice saying, really like that per diem component. It almost makes too much sense from my perspective. Thanks for sharing. So clearly, I think some of your approaches are resonating with a few folks in our audience. And please keep your questions and comments coming in the chat, and we're happy to shout them out.
All right, and next slide, we'll be hearing from Hennepin County. All right, so thank you, Josh. I want to say thank you as well. I think that's incredibly valuable information, and I love the innovation and the and the harm reduction approaches you're taking there. I just think they're saving so many lives. So I'm excited to hear about some similar from Hennepin. Amy, Naomi, I'm not sure who's next, Amy or Naomi.
I think I go first. All right, you can go to the next slide. We'll start there. All right, so my name is Naomi. Again, I am a family nurse practitioner. I work for Hennepin County in Healthcare for the Homeless. I specifically support the medical services at our COVID isolation hotels. And so I'm going to speak a little bit about that today. I will be speaking from my perspective as a medical provider, and so we'll mainly be focusing on our healthcare services at the hotels, but we'll try to give a comprehensive overview of what we do there as well. So next slide, please. All right, so Hennepin County first opened their COVID isolation hotels early spring 2020. We started off with 40 beds. We now encompass 79 beds across 2 different hotels. Both hotels are located in Minneapolis, very close to downtown, which makes it easy-ish for us to get people there and helps with discharging as well. One of our hotels is just for individual adults. The other hotel is for homeless families as well as individual adult overflow. I would like to say that all of our isolation hotels are voluntary. That means that it is voluntary whether someone goes to the hotel. It is voluntary whether they stay throughout their quarantine period, and they are technically able to come and go while they are isolated, although we do really encourage a true isolation. And so this means a true isolation would mean that someone would stay in their space. And if they left their space, that they would be masked and stay at least 6 feet away from other people at all times. Isolation within Hennepin County is mainly due to homelessness. So this means that the people who are being isolated at our hotels don't need a higher level of medical care and are staying at our hotels because they do not have another space to isolate. Our model of care involves on-site staff and virtual staff. Our on-site staff currently are mainly contracted shelter service providers. So their job is to run the hotel. So they provide meals to the patients that are staying there. They also meet other basic needs. So when it comes to needing clothing or answering questions or helping with maintaining space or laundry, those kind of things. They also communicate needs to us as they arise and as they are notified. Currently, our virtual staff involves all of our medical staff members. That includes family nurse practitioners, psychiatric nurse practitioners, nurses, medical assistants, and our epidemiology team, who we work with very closely. Most of our care is provided via telehealth. Usually it's an iPad visit or telephonic care. Another really important part of our team that I would be remiss not to mention is our triage line. Hennepin County formed a triage line back in the spring. This line is run by Healthcare for the Homeless, as well as Hennepin County's Incident Command, which was set up when the pandemic began. Their job is to answer phones. Their role with isolation mainly involves answering questions, whether that comes from hospitals, clinics, advocates, patients themselves, community members. They are also the first line of contact when it comes to intake into one of our COVID isolation hotels. They also do a lot of other work in terms of supporting our other hotel services, which Amy will talk about later, and our Healthcare for the Homeless closed door clinics as well. You can, and I just wanted to say, in terms of just the foundations of our isolation as well, we have had 527 total cases or people isolated in our hotels, our isolation hotels, and have had 270 positive cases since the pandemic has begun. On average, folks stay in our hotel for around 10 days. So through a normal isolation period, we do have people that stay longer. Most of the time, if they are discharging before 10 days, in most cases, it's because they either choose to leave or are asked to leave, so separated. And I can talk a little bit more about that in a bit. So in terms of isolation intake, like I said, that first point of contact is often the triage line. Usually it involves two different scenarios. So either a patient is calling themselves or a hospital, clinic, advocate is calling for a patient. People either are calling with symptoms of COVID or after a COVID test that is pending or after a known COVID positive result. The triage line nurse then will screen the patient, determine that they do need isolation, and then they will confirm their homeless status. And so when we think about homelessness, this means that a patient either is homeless in the sense that they don't have a place to formally stay, or that they do not have a place to isolate. So we will get some people who were staying at their mom's, but they cannot isolate at their mom's house, or people from shelter. And so that intake nurse verifies those things and then assists the person to get intaked into one of our hotels and with transportation to the hotel. Once they are there, I wanted to talk briefly about some of our medical services that we are able to provide them. So oftentimes the first point of contact is a nurse intake. And so this will be done via telephone. The nurse will often call. Their main goal is to get a brief overview of who the patient is, what some of their medical needs might be while they're there, what is their symptomatic status, are there any emergent needs that they might have, do they need mental health support, do they need substance use dependent support, and how might the trajectory of their time in isolation be, and how can we support them? So this is all documented in our chart and is then forwarded to whoever the next point of contact might be. That might be me as the provider, it might be the mental health providers, it might be epidemiology, but who is able to meet those initial needs of patients coming in. Every patient who is staying in our COVID isolation hotels is called daily for a symptom screen. This is done by nurses or medical assistants. They will ask them about COVID symptoms. They will also ask them if they have any additional medical needs that need to be addressed. Often these would be, I need a medication, or I want a mental health provider to contact me, or I don't have any clothes. Can someone help me get some clothes? And so this allows us to kind of keep track of where people are and address their COVID-related symptoms when they have them and give them the best care that we can, but also to track some of those social needs that they might have so that we can help aid them in a successful isolation period. I think our goal is really to allow people a space to quarantine. And the best way that we can do that is make those chances that they have to go out into the community to make those not a priority, but also to meet those basic needs that they might have while they're there. In terms of chronic disease management, we all know that when people get COVID, that doesn't mean that their chronic diseases go away. It oftentimes means that they can become more difficult to manage. And so some of the way that we address this is to do that initial intake where we're understanding what medication needs that they might have and what care needs that they might have. But also when we speak to them on a daily basis to make sure that they still have their medications, to make sure that they don't have any additional support. And sometimes this would look like doing glucose checks when someone is there, or helping them get a blood pressure monitor if they don't have one and need one. I do also think that the time when they're isolated allows us to spend time doing some of that teaching that we might not otherwise have the opportunity to do. Many of our folks just stay in the room most of the time. And so this allows a breadth of time for us to provide disease-related teaching and medication-related teaching that we might not otherwise have. I did a iPad visit with a patient last week, and he had been on a number of medications for years and did not know why he was on them or what they did for him. And so he just took every bottle one by one and held it up to the camera, and we sat and talked about it. Talked about the medication, how often he's supposed to be taking it, why he's taking it. He was able to have the time to tell me the history. And so I think that patients don't feel rushed. And in turn, I, as the medical provider, feel less rushed as well. In terms of medication refills, we have a pharmacy that we work with directly that's able to deliver to the isolation hotel. They're able to do that once a day. The staff on the ground at the hotel also can act as runners, and so they can physically go pick up medications from pharmacies out in the community if we need them to. And this has been a major asset of our ability to keep people on their medications, keep people stable during this period of time. Mental health. Healthcare for the Homeless has developed a robust mental health program virtually since the pandemic began. We have a number of psychiatric nurse practitioners who are able to see people via telehealth. This has expanded, I think, our reach and has increased how quickly we're able to contact people, address their needs, get them the medications that they need, and ultimately give them continuity of care. And so we are able, as providers and nurses, to just reach out to them, and they're able to call patients directly in the hotel and have that the same information that we do with chronic disease management. They're able to gather much of that as well when it comes to mental health, and they're able to take the time to really meet with their patients. Care coordination involves the work that our nurses and medical assistants do to meet all of those outlying medical needs people might have while in isolation, whether that's getting equipment for a patient, someone on methadone who needs to figure out how to get to their methadone clinic every day safely, or get their methadone delivered to them, coordinating with treatment centers for someone who comes from there to make sure that we have everything we need to do good medical care for them, and respond to emergent or urgent needs that patients have. We do have care coordination nurses on 7 days a week, and so they work weekends as well to address those needs. Discharge advocacy. We have been on a journey with discharge throughout our isolation hotels. What we have learned is that if we can start thinking about discharge from day one, so at that intake visit, if we can start asking questions about what patients envision for their discharge, it allows us to start thinking critically about what that looks like on our end and start advocating for the safest discharge possible that we can. When we have not done this, when we've given, a day or the same day to figure out where people will go when they're discharged, our ability to advocate for safety has been incredibly limited. If we are able to take the time to think about what's happening and what's available to them, we're able to advocate for hotels when it's appropriate, or figure out whether they can go back to a mother's, brother's, friend's house if that's where they're desiring to discharge. And it allows us to think about their COVID care in the sense of, is this a safe place for them to go disease-wise once they are done with their isolation period? I also think it allows patients to start thinking about what discharge looks like for them. I have had numerous calls where I am preparing to discharge someone, and the 10 days have gone so fast for them that they have not even been considering that today or tomorrow is the day that they're leaving. And so I think it allows discharge to be less jolting for them, and allows for a smoother transition. We also have a low barrier method in terms of providing substance use disorder care and counseling. Again, this can be done virtually. We have a number of family nurse practitioners and psychiatric nurse practitioners that are Suboxone waivered, including myself, to try to increase access to our folks staying in isolation. We also have a licensed drug and alcohol counselor who is able to do Rule 25s via telehealth and follow patients once they leave. And we are just starting to add into our intake process conversations about specific substance use disorders and plans for the future. If someone is really looking for some sort of treatment, maybe not interested in detox, maybe doesn't need to be hospitalized and isn't going through severe or moderate withdrawal, we can start planning that stuff while they're in isolation, while we have them there. So that's just a little bit about what we do from the medical perspective. I am going to turn it over to Amy Gordon, who's going to talk about our senior and high-risk hotels.
Thanks, Naomi. And we had one question, obviously same question for both of you on this one. Can you just be a little bit more specific? Can you tell us who you are as an entity? Provider group, part of a health system, county health department, FQHC, et cetera?
Of course. So we work specifically for healthcare for the homeless, but we are part of Hennepin County. So we are part of the largest by population county in Minnesota.
And I can add to that too, Jamie, if you want to move ahead. So thanks, Naomi. As a piggyback with that, my name is Amy Gordon, and I'm a family nurse practitioner as well. Naomi and I work together. And to follow up on that, we are part of, so our project, the Hennepin County Healthcare for the Homeless Project, is a small entity that is inside our public health department in Hennepin County. So we are just a portion or one small project within our large, grand public health department in Hennepin County, which is one of the largest counties in Minnesota, specifically encompassing Minneapolis, but then also surrounding suburbs as well. So my portion in this is to specifically talk about other hotels that we put up at the beginning of the pandemic. So starting in March, we started 2 senior and high-risk hotels that are on the southern border of Minneapolis into one of our suburbs called Bloomington. And this was all Hennepin County, the public health department as a whole, that has leased these 2 particular hotels in this one suburb. And then the Healthcare for the Homeless project, so in which I am part of, helped to develop various criteria for the folks that were going to then be moved, provided they agreed to be moved, from shelter specifically in the beginning into one of these hotels. And so I was part of the team of folks that came up with the eligibility criteria to move folks from the shelters into these hotels early on. So early in the beginning stages of the pandemic. And the criteria that we developed came a lot with working with other stakeholders in our community and community partners, with Minnesota Department of Health, with guidance from the CDC, but then also the human service sector, as well as the our other community partners and shelter service providers that were within Hennepin County. So our elderly population was our first criteria of folks that got moved to these two hotels in particular. So 60 plus, and they are single adults. So I should say that specifically, these two particular hotels are for single adults as well. So if you were 60 or older, you met eligibility criteria provided you were in agreement to wanting to move to one of these hotels. Other than criteria that kind of cascaded down were comorbidities. So heart disease, lung disease, COPD, asthma, diabetes. So the big chunk of big system problems that led to comorbidities was another eligibility criteria to be moved into one of these hotels. And then immunocompromised individuals, as well as, and I put sheltered versus unsheltered, because again, we started with a couple of our largest single adult shelters in downtown Minneapolis, and we started from there to try to fill these hotels. And once our sheltered population who were in agreement to being moved, we then went into the unsheltered population as well, asking, trying to move people from street homelessness into these hotels. Our model of care, very similar, and of course we're utilizing the same resources as what Naomi talked about, but specifically for how these particular hotels were rushed to be set up, we have human service providers that specifically work for Hennepin County, and a lot of them were diverted from their actual jobs within Hennepin County because their service sector was closed during the pandemic or shut down, so to speak. And so they were then diverted into providing other care as part of their employment. And some of them were then moved into this particular sector of being on-site providers at the hotels. So we're still part of Hennepin County, but it was the human service part working with the public health part in trying to merge these two entities to provide services for the folks that were at or that are at the hotels. So human services on site, that those folks were social workers and intake people that were providing like SNAP benefits and housing resources. So many different parts of the human service sect were coming to be on site to then provide these services in the face of trying to then also promote public health, which, since we are a smaller portion of that, we don't have as many people working within the healthcare for the homeless. We then provided a lot of remote services and trying to provide education not only to the people staying at the hotel, so the clients, but also for the human service people that were then providing the on-site services there as well, providing guidance, helping them to ensure that we weren't using communal spaces inside the hotel, and that they definitely were staying 6 feet apart and they were wearing masks, and there's only a certain number of people allowed in the elevators going up and down. I mean, it was definitely a very great learning curve for a lot of people early on in the stage, and it's still a learning curve to this day because a lot of the on-site service providers rotated in and out every 2 weeks. So every 2 weeks, we would get a new group of human service people to be on site to work with the clients. We now have, one of the hotels continues to have human service Hennepin County people at it, and the other one we now have a service provider, an outside service provider that has come on site to provide these services on a longer term basis. So we are transitioning through that as well. As far as the public health, the medical and mental health providers, as Naomi stated, for healthcare for the homeless, we provide mainly telehealth visits with video conferencing through iPad visits. We have sessions that are developed during the days. So at least 2 days out of the week, we have 4 to 5 hour chunks during the day that are specifically for medical visits that clients can sign up to have a medical visit. There are also those opportunities with mental health providers as well through Healthcare for the Homeless, so we can have video conferencing through our iPads. Those iPads are taken to each individual room and rolled in on a cart. Once they are finished, they're rolled out and sanitized, and they get moved to another room after we are finished. We also have done it where there is one room within the hotel that is utilized for the telehealth or the video conferencing, and the patients come in and out of that after they're sanitized from the previous one. So we have done that in a couple of different ways. Also, we do a lot of telephonic encounters simply because, and as Josh had stated before, in our community, oftentimes the cell phones are lost or minutes aren't paid for. And so we have really greatly utilized the hotel telephones to be able to help us with the majority of the telephonic encounters that we have. And it has been vitally crucial for us to be able to provide care using those telephones inside the rooms. And the patients love it as well because they then can get our phone numbers. And so we can make it much smoother and easier for communication versus going through various steps to try to get information disseminated. We also, as Naomi is stating, we have pharmacy delivery. So since we are an FQHC, which I don't think we were specific about that, but we are a designated FQHC, we have grant funding that provides pharmacy services, and we then have deliveries out to each of the different hotels once a day. I also am able to utilize community partners such as community paramedics that are through our Hennepin Healthcare system. So it's our large medical system in downtown Minneapolis, and I can utilize community paramedics to go on site to do COVID testing, influenza testing, point of care labs. They also draw labs or INRs if I need to help monitor somebody's INR if they're on Coumadin. So we have access to that. We also have a program, so part of HRSA, I'm also the provider that does the respite management or medical care within our respite. And so we do targeted visits now. We have transitioned from our typical respite in one of our largest shelters in downtown Minneapolis to out at the hotels. And we have targeted visits for nurses and licensed social workers and pharmacists that are either on site or do telephonic or video conferencing with patients to be able to provide those services as well. Next slide, please. And then I wanted to just kind of highlight several things that I find as being challenging, ongoing challenges, things that we have learned, as well as successes and opportunities throughout this process as it seems like it's not going anywhere anytime soon. One of the largest challenges early on and still to this day is the location of these two hotels that we put up really early on, and hearing that the majority of our patients are coming from downtown Minneapolis and now being moved to a surrounding suburb. A lot of our folks don't have access to various services and needs and buses that they know or know how to get in the new location that they are in. Both of the hotels are right next to pretty major thoroughfare highways, and there aren't a lot of other businesses near the hotels. So even like basic things like getting to a post office or going to a pharmacy, excuse me, they don't have access to that. And some of the the actual shops that are near one of the hotels have also complained about the clients who have been coming and going in and out of their businesses. So that's been a challenge. But on the other side of things, the opportunity and the success of actually moving these high-risk individuals out of congregate living into individual spaces where they have their own bathrooms, they have meals provided to them 3 times a day, they have access to medications, that has all greatly improved the virus mitigation. And as Naomi had presented the numbers before, pretty significant mitigation, I would say, with not having a horrible increase in the numbers of patients that have acquired COVID while experiencing homelessness. So I do think that the strategy that we tried at the beginning and that we're still doing to this day has been helpful to our patients. Another big challenge is the contract and the policies of what the patients have to sign and agree to while they're at the hotels. And these contracts were developed by Hennepin County. So part of the health department helped to construct these contracts and the policies around it. And initially, somewhat punitive in responses, in that various behaviors get automatic discharges from hotels. And an example is alcohol use. So alcohol is not, or in the contract is stated that they cannot have alcohol in their rooms. If it is found, they get discharged. And in that, they then aren't allowed to have access to any other hotel within the Hennepin County system if they get discharged from another one. So that has been a big barrier for a lot of our individuals with substance abuse and not having a true harm reduction policy at those hotels themselves. And we have worked tirelessly, and I would love to have some peer people that Josh spoke to come out and help us with this piece, because it would be crucial, I think, in continuing the work that we're doing. But on the other side of things and opportunities around this is I have done a lot of work around getting our folks that are hepatitis C positive treatment while they're at the hotels. So since they are stable, they're easily accessed by telephones, and I have medicines that I can be able to deliver. I have been able to successfully treat at least 6 to 8 individuals that now are without hepatitis C. So if nothing else, I mean, I am not happy about the lack of harm reduction, but I'm also excited that we're able to successfully treat people with, say, hepatitis C. We're also able to have some robust efforts in getting vaccinations for our clients. So influenza, pneumococcal, hepatitis A, all of those are being readily accepted by patients. And during our targeted RN outreach, we have those vaccine clinics where people are able to get vaccines updated. And then we also, since they are in places where they are more consistently in one space, we are able to improve our efforts with preventative care. So trying to get mammograms and colon cancer screenings. I mean, it's not fantastic, and I would love to have more opportunities of working harder at getting people tested and screened, but we're still doing work around trying to get our chronic disease management as well as our preventative management access. And then with that too, I feel as though folks that are in the hotels are getting better access to medications on a regular basis, and therefore their adherence to medications has greatly improved since people have been out at the hotel. So those are definitely some successes from the people being displaced from street homelessness and sheltered homelessness into the high-risk hotels. I spoke a little bit about the no tolerance substance use policy. As Naomi had said too, we do have people. We have Suboxone waivered providers who are able to provide Suboxone, in which it also can be delivered through our pharmacy. So that is a great service that we can provide. We do have our people who can do the Rule 25s as well. We do offer opportunities for treatment if that is something that is within people's desire during this time as well. So, we are working around and trying to offer services. It's just the lack of harm reduction that is the biggest challenge at the hotels. And then the other big thing that I wanted to highlight at the end of all of this is our Hotels to Housing project that now is underway. And we have anywhere between 100 and 150 people at each hotel. And that has been kind of ongoing, revolving since the beginning in March. And therefore, it's around 300, 350 people that we are medically managing out at these hotels. And it has now come online that we are doing this Hotels to Housing project where all of these individuals that are currently at the hotel, the goal is to have them housed in an appropriate housing situation, as Marcella had mentioned before, in that it's either GRH funded housing, it is group home, it is assisted living. So whatever the person's needs are, as well as what their desires are, we are helping them. We have licensed social workers that are helping to then place them into housing versus having them go back into shelter or street homelessness. So that's a big win in our world within Hennepin County to try to get folks housed from these senior and high-risk hotels. Next slide. I think that's done.
All right, so we've got a couple of questions in the chat that I wanted to bring up. And this, Amy, this could be you, for Naomi, for Josh. Love to hear what all of you have to say on this. First one is, on average, how many telehealth visits do your providers do a day? Amy, definitely for you.
Yeah, I can take that on. So it is, I'll say it could be anywhere between 5 visits to 15 during the day. And these are all self-identified individuals, typically. Sometimes I get messages from Naomi if she's discharging a patient from the isolation hotel and they're being moved into one of the high-risk hotels. She will send me a message that says, please follow up on this. And then that guides me into interacting with somebody. But otherwise, most of our encounters, again, anywhere between probably 5 a day to 15 a day, are folks that have self-identified having a request, wanting to talk to a medical provider.
And I would say just in isolation, it's a little bit different because every patient is being called every day and asked, do you have any concerns? And so I'd say on like an average day, I see between 9 and 10 people. And I think a lot of it is because people are being prompted for visits. The other thing with isolation is that the majority of our patients are symptomatic. So there tends to be a higher need.
That makes sense. That makes sense. Josh, what about you? I saw you smiling and nodding for some of Amy's comments.
Thank you. I was smiling and nodding at the 5 to 15 a day. There's no way to compare apples to oranges in this, but we do about the same.
Yeah, that makes sense. Okay. Next question. Amy, I think this is also for you. For the sites that you're in, do you have to address any building code or safety considerations for setting up the hotel as a healthcare site? Code entities, do you change zoning or anything for changing and repurpose the usage from a hotel occupancy to a medical occupancy? And that was the question. I'm not sure that you're changing it from a hotel. At the end of the day, it's still short-term housing, it's still a hotel. There are just these extra services layered on to a hotel is how I might frame it, because I know one of the things I always try to avoid is any way possible is going near the zoning board.
Yes, so I mean, that's not really in my wheelhouse, knowing that I'm a medical provider, but I can tell you how the hotels are looked at in the eyes of, say, the health department, is that they are apartment style housing. So, I mean, they don't all have their own separate entryway, but they have their own bathroom, they have their own space, they have their own bed, they have a refrigerator and a microwave. And so therefore they are considered apartment style housing. And so as far as I know, and again, I'm the medical provider here, there's been nothing addressed about coding. And since we are providing the majority of our medical and mental health appointments, telehealth and video conferencing, we don't have a specific room that is used just for medical purposes.
And I can say that definitely I'm not an expert in this area, but it seems like I spend 100 hours a week in this area. We only just got insured under this on Thursday or Friday last week, and we've been doing this since the beginning of April. There's a lot of nuances. My general take, if it helps anyone, is that it be approached from a homeless perspective. And we actually ended up, without going into the weeds, with two groups, a group one and a group two, following two different definitions of homelessness under two separate rules in our funding mechanism. Because ultimately, when you boil down through the CARES Act money and the ESG and COC funds that are converted into FEMA funds, nobody knows what's going on. But if you take it at face value and provide it from a homeless perspective, right, and provide it as we are providing a subsidy for you to live in this unit, and this is your unit, you end up with a whole lot more autonomy and person-centered approaches than you can if you structure it as a shelter and as a program where people have to enter and follow all the rules and expectations that, you know, a homeless shelter and ESG program requires of that's required from HUD, and then layer the healthcare on top of that as if it's home health, right? I mean, our care managers and transition nurses and whatnot are accustomed to going out when people come out of the hospital and go home, or going into the hospital to help that transition. And that's the way we chose to approach it. So our care managers and health coaches and people and other providers that are doing the telehealth are doing home visits. Though I understand that a portion of what we do is in scope, and HRSA has been very, very reasonable to work with in all of that. But it gets complicated when you look at everybody's rights. But I think that's the least complicated, is having that hands-off approach and then doing the home health.
Yeah. That certainly fits with I'm going to jump to one of our other questions. Can folks talk about reimbursement aside from grant funding, bed rates, Medicaid billing, hospital MCO relationships? I put in the chat National Healthcare for the Homelessness Council paper on Medicaid and managed care financing approaches for medical respite. I think that would be a good paper for folks to think about. But for you two, share it with us billing wise. What's going on from the financing perspective?
I see that you're still muted, so I'll hop in. We're, for all practical purposes, 100% grant driven. Right now we're operating under the FEMA funding, so we're in large part. The state is operating in large part under FEMA funding. We're still using CARES Act funds to stand up the hotel and to provide all the operational support for it. The remainder of everything that we do is really home health, and that's billed the same as if people were transitioning and quarantining in their own homes, or quarantining in the shelter as is. It's just 100% telehealth.
Naomi, you might know this more, because again, we have billing experts that help us with our billing and coding from our visits. But Since we are a federally qualified healthcare center, so we bill according to those guidelines. During this time, we are, and since we can bill through with video conferences or video encounters as well as tele-encounters, that is how the majority of ours, our funding or our billing is working. And we have specific phrases that we use and we base it on time. So all of our visits are based on time versus like what we're actually doing, which is how we've had to bill in the past. I can tell you too that since we are grant funded as well, my salary right now is coming from CARES monies that is coming into Hennepin County versus how it was previously. So I do know that that has switched as well during this time, knowing that I am specifically medically managing the high risk and the senior folks that we've displaced.
And just to add to that, we do have a low barrier method to getting people on in contact with a MNsure worker. We actually have a specific, they're able to call our triage line. So that's another way our triage line works is they're able to call them, press a number 3 and get directed directly to our MNsure staff, who is part of our Healthcare for the Homeless team. And oftentimes, if there are no outliers, she's able to get people on insurance within 24 to 48 hours. So that is a major asset to the way that we're able to function and provide our medical care and for our project to get reimbursed.
Can you, MNsure, that's not a term I'm familiar with, so my guess is it's a Minnesota specific term. Yeah.
Yep. Yeah. So that's just the name for our like Medicaid program.
Okay. So it's like a benefits counselor who's helping people, screening people and helping them determine what it is they're eligible for. I always make a distinction between people that are eligible and people that are enrolled. My guess is you're finding a lot of people that are eligible, they have the characteristics, but they're not enrolled. They haven't signed up. There's, the chaos of life on the streets does not do well with the Medicaid bureaucracy.
Yep. Yeah. And especially, health insurance. Yep.
Okay. Do you know if they screen for any other benefits, Social Security or any other benefits besides health insurance?
So we do also have social workers who work specifically with Social Security and help guide that process as well.
Awesome. That's exciting. Okay.
And they're part of the Healthcare for the Homeless team.
That makes sense. That makes sense. Yeah, like a SOAR worker. Here was another question. Can the presenters discuss how the emergency responses might evolve and continue to the future? How and where do you see these projects and processes going? I see for some people, particularly in Minnesota, you're working to identify housing-related resources and move people on their forward. But how else do you see what you've learned here bringing into the system, bringing in knowledge to the system?
Wow, that's like answering all the silver linings of COVID-19 all at once. There's a ton. Some of the things that have spurred from standing up this hotel in the greater Bangor area are discussions around safe injection sites. I don't think we're there yet, not even close, but we weren't even close to having that conversation before. We have the transportation barriers coming down. All of a sudden now everybody is aware what happens when a marginalized population is unable to get to a methadone treatment program or to their Suboxone or to get their medication period, any form from the pharmacy. We're finally able to have conversations where the rubber meets the road. We've long held the principle that the next available service is for the most vulnerable person. But that hasn't always played out in our community, where the person with the cell phone or the loudest care manager advocate gets that person to the next available resource. We stood up a triage and diversion line that matches vulnerability through a vulnerability assessment with length of time homeless for our next available resource. And so that principle is now playing out. I think it travels on. Homeless shelters. I've run a homeless shelter for a long time, and I think that congregate living, mass shelter is the most ridiculous thing we do to grown adults on the planet. And now everybody is seeing that, right? I mean, the difference, and the choir's on this call, but the difference between pulling somebody out from living under a bridge or living in an encampment and bringing them to the shelter, a mass shelter, versus bringing them to a hotel where after 2 or 3 days, the cobwebs can get wiped out. You can take a shower in your own shower. You can get some makeup on. You can put some clothes on. The difference in the amount of dignity you provide somebody when they have their own door to shut and their own telephone to call. You know, one of the earlier conversations when we were putting people in hotels with local emergency services was that people were calling the emergency services for things that, and there were complaints about this at first, right? But this is a civil liberties issue. Right now, people can actually call when they're being abused, when before they couldn't hold on to a telephone or charge it in an encampment and whatnot. All these things are coming to light, and it's going to change our system for the better forever. I hope that one of the things that goes away is mass shelter. The proof is just in the pudding and looking at somebody's face. So I could probably hog the rest of the 7 minutes, but those are my initial thoughts.
They're good thoughts, but Naomi and Amy, we'd love to hear from you too.
I think the versatility in healthcare, the fact that we can take care of patients in a flexible manner that can be conducive to what they need and we can respond appropriately has been a highlight of learning for me. Watching our mental health team be able to respond rapidly when before we had to tell a patient, come back and see so-and-so on Tuesday afternoon when she's in such and such clinic. Where now we can have this psychiatric nurse practitioner call a patient within an hour, meet the needs that they have. And a lot of that is possible because of what Amy and Josh have been saying, the fact that we have access to phones. And so I think that it is a snowball where we provide access to a more dignified way to shelter, we provide access to phones, and then we're able to provide a form of medical care that is able to meet people where they are and be flexible when they need it.
I love what both folks are saying. I'm going to piggyback what Naomi has to say about the flexibility and the low barrier aspect to medical and mental health care, as well as substance abuse, education, and services. So we do have a fairly robust medical outreach and mental health outreach team that is part of the Hennepin County Healthcare for the Homeless project as well. So we don't just do hotels and we don't just do shelters, but we have a pretty extensive, and it has gotten bigger during the pandemic, for our mobile outreach. And so I think that safe injection sites are definitely conversations that will be happening, that are happening. We do have people who are working on our HIV and hepatitis A epidemics that are happening around our city as well. And so we're doing a lot of really great efforts around those specific illnesses and diseases and transmissions and education as well. And I think, and I would put in a plug too with homeless hospice, which I think is something that is pretty vital, that is necessary, specifically talking about people's autonomy and decision making and dignity around their own health and health journeys. So that is something that where I would like to kind of forge into in the future as well, knowing that we need to be able to provide people spaces with and choices of what they want to have happen with their own health journey.
That's great. That's great. All right. Well, I think we're through the questions, and I just want to thank everybody, particularly thank our presenters for taking time out of their incredibly busy schedules and sharing their really valuable and helpful and knowledgeable information. And I just want to thank each of every one of you who are out there supporting hotels, supporting people in your communities throughout this pandemic. We hear again and again how healthcare providers are just going above and beyond. We know that that's what you all are doing as well. And so just really want to say our thanks for helping keep our community safe, the vulnerable members of our community, and just our communities as a whole in public health, from a public health and population health perspective. So thank each of you very much. I hope this was valuable and great learning. I know I got such a great deal of learning from all of our presenters. So thank you all.
Thank you for having me.
Yes, thank you so much.
All right. Thanks, everybody. Have a good afternoon or morning.
Thank you.